Good afternoon. So I was asked to talk about how do the three topics of this workshop, cultural competency, language access, and health literacy, how do they integrate with wider efforts to reduce disparities and improve outcomes and improve equity? And at the breakfast this morning, I was talking to Bob Logan and Ernestine Willis, and they said that one of the strengths of the roundtable was that it was bold and not afraid to suggest innovative ideas. And I talked also a little bit to Ignatius Bau and Alicia Fernandez and Michael Pash-Orlo, and they all encouraged me to basically not hold back, to be honest, and to say what I really meant in terms of assessment and recommendations. So I hope not to disappoint. My main messages, by the way, are going to be that first, I agree with Michael Wolff that the three fields do have a danger of potentially stagnating and being too insular and siloed. Second, we need to do more in terms of integrating with existing quality and equity initiatives. And then finally, we do need to do a better job of creating a business case for these different areas, while at the same time, as Dr. Rosoff, I think very importantly said this morning, nurturing the inherent motivation and values people have for working on reducing disparities. The closest to a for-profit relationship is the grant from the Merck Foundation, which is the philanthropy funded by a Merck company. For those interested in more information, there's this article in the packet which goes into this in more detail. A lot of this comes from the Robert Johnson Foundation Finding Answers program that Ignatius mentioned, where we had 33 grantees, 12 systematic reviews of the healthcare disparities intervention literature, and then we provided technical assistance to quite a few different organizations. So we learn a lot through the School of Hard Knocks. So here are this six-step roadmap, and I'll go through the 6 steps in more detail to reduce disparities. The point I want to make about this slide is that I think nationally we have focused upon 2 of the steps. Number 1, recognizing disparities, and number 4, designing interventions. The point, though, is that if our goal is sustained change and improvement, we need to address all 6, and we're not going to get there if we just focus upon 2. So the first step, recognizing disparities and committing to reducing them, 2 things I'd like to talk about here. So one, we've talked a lot about examining performance data stratified by race, ethnicity, language, socioeconomic status. What this does, though, is that it basically increases people's motivation to change, that people have to see their own data to acknowledge that there are disparities in their own practice. They won't be motivated to change unless they are convinced that there is actually an issue in their own particular patients. And the second point is one that I think is one to emphasize here, is that sometimes I think that cultural competency programs have been too narrow, and that, and here's where it may be a little bit insular, that in some ways I think it may be a more appropriate phrase, disparities training. The Society of General Internal Medicine has goals for health disparities courses, and I think, Alicia, you were part of this committee, right? Yeah. And they have like 4 different goals, which I think are more encompassing than a typical cultural competency course, talking about the existence of disparities, the cause of disparities, solutions, addressing mistrust, subconscious bias, sections on communication and trust building, and then very importantly, building a commitment to reduce disparities in the trainees. That's one thing, for example, to teach a cultural competency course, it's nothing to get people to actually buy into that this is an important thing to work on. And cultural competency courses, I think they're actually difficult to teach well, and they'd actually be counterproductive if not taught well. Now, at the University of Chicago, the first-year students, the first 2 courses they take are anatomy and healthcare disparities. It's a required course. The woman on the upper right, her name is Monica Vella, and she's taught this course for about 10 years or so. And I'll give you some examples of the things that she does in this course to make it a little bit different than some of the other courses I've seen. So on the first day of the classes, there's a self-insight exercise. So think of the first words that come into your mind when you hear the word physician, when you hear the word welfare recipient. So it's an entree into talking about subconscious biases. There are field trips where the students will go to the south side of Chicago where patients come from, so they learn where the patients are living. There's a great section on Chicago history where an urban sociologist comes in and talks about why housing in Chicago is segregated. And you learn that it's not just by chance, but because of a conscious set of policy decisions and decisions by businesses. There's a group disparities project where students work in small groups to actually do a disparities reduction process. Reflective essays, discussions. It covers everything from individual patient care, like working with interpreters, to macro policy, like Medicare. And then over the past 2 years, there's been a new segment on advocacy. And it's because Monica found that without the advocacy component, students actually felt disempowered. So, counterproductive, that, we have all these problems, but they probably want the ability to do more. So that's actually now part of the course title, Advocacy. Now here's a sobering thing that, I think there's been magical thinking about stratified performance data and cultural competency training. The data are that stratified data and cultural competency training alone do not improve clinical performance measures. Something like blood pressure control or like sugar control in a diabetic patient. The disparity data interventions are helpful for raising awareness, but don't move the clinical numbers. Similarly, the cultural competency training improves attitudes and knowledge, but not enough to improve then the clinical outcome measures. So they're good and they're helpful, but you have to combine them with other type of methods, which I'll talk about now. So you may have seen this before, that so Hillary Clinton, maybe about 6 weeks ago, she was talking to the man on the right after one of her campaign performances or presentations. This is a man representing the Black Lives Matter campaign. So this is the campaign to try to reduce violence by police against black men and women. So Hillary Clinton says, you can get lip service from as many white people you can pack into Yankee Stadium, and a million more like it who are going to say, we get it, we're going to be nicer. She says, that's not enough, at least in my book. She then went on to say, I don't believe you changed hearts, summarizing her basic view of social policy movements. I believe you changed laws, you changed allocation of resources, you changed the way systems operate. Well, I think that, her statements, I think, may also apply to the disparities, healthcare disparities issue. I think there are some things she gets wrong here and some things she gets right. What she gets wrong, I think, is that I think it is important to change hearts. That you got to change, people's motivation. People got to really believe it and feel it's really part of their social values to improve equity. But at the same time, she's right that you got to change the laws. You got to change the allocation of resources. You got to change the way systems operate. That it's not just cultural competency training. It's not just data. You got to have the systematic changes. I had a nice lunch talking to sitting next to three of the folks from industry on the round table. So it was Terry and Laurie and Kim. And one of the points they made, I think, goes along with this slide, that if you want something like disparities to be not a marginalized activity, you got to embed it into the basic operating structure and people's basic jobs. So in a company, for example, you got to make it relevant to their basic jobs. So again, it's not sort of a, we do check, literacy, and it's a checkbox. We've done our event for the year, but it's part of what they think about every day. What that means is making equity an integral component of quality improvement efforts. So you see the two IOM reports here, and I think that too often the people who work in quality are different from the people who work on equity, and ergo the problem. This is IOM, but I think probably a lot of people haven't seen this slide and don't realize that in 2010, the IOM redid their model of quality. So equity used to be one of the 6 pillars of quality. If you look at now up far left, equity was thought to be so important, it was then taken to be a cross-cutting dimension that then cuts across all the other 6 dimensions of quality, effectiveness, safety, patient-centeredness, et cetera. So again, a fundamental conceptual change. You think about equity in everything you do in quality. So the fourth step is designing interventions. I'll talk a little bit about root causes and 6 levels of influence. The point I want to make about root causes is that there's no substitute for talking to the patients and community members that you're working with to try to help with their health. I think a mistake a lot of people make is that they talk to proxies, so in particular minority healthcare providers. We're going to do an African-American intervention. We'll talk to our African-American doctors and African-American nurses. They'll know what to do. Well, maybe they do, and there's a good chance they may not, because there's probably a good chance that they have a different background than where the patients are from, in terms of potential class, for example. And so, we have like one example, one of our grantees was a neighborhood health plan in Rhode Island, a Medicaid health plan, and they tried to do a depression telephone intervention for the Latino patients. Talked to Latino doctors and nurses, designed a telephone intervention. They had trouble enrolling any patients. 2 main barriers were most of the patients had cell phone minutes that were pay-by-the-minute plans as opposed to unlimited minutes, so people couldn't afford it. And at that time, the governor was starting to crack down on undocumented workers. So these were things that the doctors and nurses, the Latino doctors and nurses, weren't aware of. So it didn't work. Conceptual model for disparities, bubble on the left, person embedded in the community. If they have access to care, become a patient interacting with a clinician, then a healthcare organization. Above that, you have the policy superstructure, the big one being a hammer being financing. You also have regulations, for example, the Joint Commission is getting involved in this now, ultimately affecting the bottom, process of care, and outcomes. So you can think about it, for example, these 6 levels of influence and ways then you can use these as levers to influence the 3 different topics of today's workshop. So for example, the policy level, you can create clinical performance standards that are linked to reimbursement, whether there's, for example, structural measures of culturally competent organizations like interpreter use or clinical outcomes. I'll talk more about that in a moment. Dennis is starting to work on a project looking at equity index tools to rate organizations. So that could be another sort of tool. And we talked about, Sarah talked about mandating through legislation. The level of healthcare organizations, there are various diversity, inclusion, equity initiatives. And so I've been at the University of Chicago now like 22 years now. So I've been there long enough that I've seen both when there had been the language of this without necessarily the true priority, to over the past 3 or 4 years, which has been a real priority, which means a true priority of senior leadership, and then the resources and a core team to facilitate and move these mountains from the organization. So you have to embed it within the existing different committees and departments, but it really helps to have sort of a core team whose job is to basically help do that. The microsystem is the immediate care team. So, for example, how can you integrate language services interpreters more immediately into care teams, making it easy to access for providers? Providers training working with interpreters, cultural comedy training, shared decision-making training. Patients, we've talked implicitly a little bit about the activated, empowered patient, shared decision-making training, easy access language services. And the community, similarly, can be community empowerment, use of community health workers, addressing the social determinants of health. So here's an important point, I think, that when it comes down to it, there aren't a lot of magic bullets. That when we looked at 400 different interventions, the closest we come up with common themes were these 6. Multifactorial interventions that attack the different levers, culturally tailored approaches being better than generic. So none of this, rise and tide lifts all boats methodology, just not as effective. Team-based care, especially good evidence for nurse-led teams, involving families and community partners, not surprisingly, patient navigators, community health workers, interactive skills-based training. But the point is then that, we're not going to have a situation where we can have off-the-shelf tools that you just basically, use in your own organization. It has to be embedded in the QI process because there has to be this adaptation to the individual context, culture, patients, setting, et cetera. So there's not going to be a simple solution. There's clearly going to be an important role for demos and model programs, but it's always going to have to be the adaptation. So implementation, so sort of a slide on implementation science. This is Laurie Damschroeder, who wrote this article in Implementation Science. In other words, you got to think about what the business people think all the time, that if you're going to implement something and have it stick, you got to think about 5 different aspects. What's the advantage of your intervention over the status quo? What are the external incentives? What's the culture of the organization? What are the beliefs of the individuals you're trying to change? And then what's your plans for planning, executing, and evaluating? And so there's the science behind each of these. This is behavior change theory in one slide. So, initially we're taught, well, you educate people. You tell them why things you should do it, and it'll solve the problem. But then we realize in the workplace that's not the way the world works, or if we have kids, we really realize it's not the way the world works. So you think about social norms that we're, peer pressure. We're part of a culture, so you look in that. Environmental, faculty incentives, and then self-efficacy, coaching, giving people the confidence they can do it. Which gets us down to, actually one more slide on this, motivation. So it's part that Dr. Rosaf mentioned, so that you've got to work on both. Both the intrinsic motivation, the professionalism, doing the right thing. There's also a role for external incentives. Which gets to the last part here in terms of the incentives, institutionalization. We had a slide earlier about the societal business case by one of the earlier speakers. I want to focus upon where's the business case. And I think the first couple speakers talked about some of these generic trends, but the point is they're not powerful enough. That, look at the ARC National Disparities Reports, outcomes are basically essentially unchanged over the past 10 years. So we have a Robert Johnson program looking at using payment reform as well as delivery system reform to try to reduce disparities. I want to spend the last part of the slide talking about CMS and private payers. So it's the 30th anniversary of the Heckler Report, which was the first major federal report to talk about disparities in black-white health. So about a month ago, I was at a CMS conference where I basically told them on one of these panels that, it's great the things you're doing in value-based purchasing, that, it's progress, but to be honest with you, you're not doing nearly enough in terms of working on equity. So I had 6 recommendations from them, which I think are actually very important for this roundtable also. First, not surprisingly, requiring public reporting of stratified disparities data, and they're going to start this for a couple of their programs over the next year. Strengthening incentives for prevention and primary care. In the current global payment ACO shared savings plans, the incentives have been relatively modest. They need to be more aggressive so that there's enough at risk that there's more of an incentive to actually do prevention and primary care. I think most of us know that the relative value payment schedules for physicians really is part of a political process as opposed to evidence-based. And so basically the cognitive specialists in primary care are grossly undervalued. There need to be more incentives to encourage the intersectoral, health, non-health partnerships. And then I think very important too, again, too much of the rising tide lifts all boats thing. We need to have specific pay for reducing disparities measures, explicit equity and accountability measures to basically have more of a financial incentive to work on disparities. The fourth one here is aligning the equity measures across public and private payers, and then taking care of the safety net providers, which we haven't talked about much today. Adequate payment, calibrating the cuts in the disproportionate share hospital payments from the ACA to the rate of insurance expansion, support for quality improvement, risk adjustment for both clinical and sociodemographic factors to create a level playing field. Dennis mentioned demo products for payment delivery form. The bottom line is having an explicit equity lens, both for the quality efforts and the payment efforts, to basically try to think about how can we design things to reduce disparities. I'll end by this quote, the last couple sentences from an editorial I had in the New England Journal of Medicine, which I think applies to a lot of different audiences, but I've been convinced and impressed by how much leadership does matter. It is our professional responsibility as clinicians, administrators, and policymakers to improve the way we deliver care to diverse patients. We can do better. Thank you.